Start or?
Short version.
Yes, we'll wait for him or normal.
I need a time, about time.
We're making this very West focus now.
Yeah, but it's good. You know what? Last year the meeting, we decided we were going to be on time.
I know. All right, everyone, if you don't mind making your ways back to the presentation side of the room. Try and get everyone out at a reasonable hour. Okay, all yours, Jason and Eric.
Okay, so as everyone starts to come back into the room, I'm Jason Nagolnik. I'm here with Eric Forget. Not Dr. Bassam Al-Tukarim, he couldn't make it today. And we're going to do section 3 now, what to do with the nodule. So I'm going to introduce our first speaker, Dr. Nicole Ezer. Her clinical research focuses on lung cancer screening, lung cancer epidemiology, comparative effectiveness, and outcomes research. Her main research interests are the application of AI techniques to health administrative data, improving outcomes of patients screened for lung cancer, comparative effectiveness of different treatments of early stage lung cancer, and the impact of racial and socioeconomic disparities in lung cancer management. And her title is Landscape of Liquid Diagnostics for Solitary Pulmonary Nodules.
All right, thank you everyone for coming today, and thanks John for inviting a pulmonologist to speak at a early stage lung cancer meeting. I think you guys are stuck with us now that screening exists. And you will see that I'll try and bring in some points about screening, but this is really to focus mostly on lung nodules. So these are my conflicts of interest, and I have no conflicts of interest with respect to biomarkers. So I'm going to quickly go through the 3 objectives. So I'm going to talk a little bit about the clinical utility of blood-based biomarkers for incidental pulmonary nodules. I'm going to talk mostly about protein-based biomarkers because these are really in use now, especially in the US, not yet in Canada, but they're the most ready for use. And I'm going to also talk about other type of diagnostics, mostly genomic-based. So another point is that I am a clinician scientist and a trialist, so I'm going to be explaining some concepts that are beyond my scope of expertise, but really with the idea of how they're used clinically. So I think what's really important when we talk about biomarkers for lung nodules is they're not really useful if it's someone that's super high risk for cancer. If I have a patient with a 5-centimeter mass, I don't even need a biomarker to tell me that it's lung cancer. So really the scope of what we're looking at is to use biomarkers in the space of patients that you're not sure if it's lung cancer or not. You have an indeterminate risk patient or a lowish risk patient. You want to avoid a biopsy or you want to surveil the patients. So I'm not really interested in how biomarkers perform in kind of more advanced stage or larger lesions. I'm really interested in how they perform in this yellow group over here. Oops. In the yellow group where you see that there's a question about what their risk is. So this is kind of a summary of all the proteomic biomarkers that exist right now, and most of these are available. I would say the commercially available one that's FDA approved is the one by Tanner and al. In 2021, and I'll focus in on that one in the next slides. But the proteins that have the most data are really CA, cytokeratin fragment 21, and most of the biomarker panels are not just one protein. There's a panel of proteins that are checked in the blood, and they're added in addition to other clinical factors. When you're looking at studies of these clinical utility studies, you take your biomarker, you also take your size, whether it's spiculated, whether the patient's smoking or not, and you add all that information and it gives you a risk score. So it's not just biomarker positive, yes, no, it's really a combination of factors. And so I'll give you some examples of how this Notify biomarker is used. So it's really a 2-protein panel, and right now there's a clinical utility study that's ongoing that we're participating in. So those are the 2 proteins on the left that are part of this biomarker panel. And again, it uses clinical factors for the patient, and it gives you a risk of malignancy. And on the right of this table, I don't know if you can really see very well, but you'll see all of these performance characteristics of these different groups of biomarkers, the sensitivity and the specificity. That's useful when you know the underlying risk of lung cancer in your population. What's more useful as a clinician is really the reclassification index. So how many of my patients get reclassified to low risk versus stay indeterminate risk. So as a clinician, I'm more interested, while I value sensitivity and specificity, I really am interested when I'm reading these studies about clinical utility. And so I'll give you an example of that. So this is the Panoptic trial, which had an underlying kind of low-risk group of patients, and they looked at the comparison of the clinician's gestalt of what the risk of lung cancer was in the patient to other validated tools we use, so PET scan, the VA lung nodule model, the Mayo lung nodule risk model, and they compared how this integrated classifier worked compared to all those individual ones. And the classifier performed a little bit better than that combination, but I would not say it's perfect. This was a registry that used the same classifier, and I'll just show you a little bit. The concept here is that on this y-axis, you see the risk of lung cancer of a nodule, and on the x-axis, the pre-test and post-test probability. And so on the left, you see that there's a wide range of risks. So these are indeterminate risks, so patients with a risk of lung cancer of 50% or less. And when you do your biomarker, it brings down most of the patients to a risk of less than 5% of having cancer, so lung cancer. So it is helpful in that this is a biomarker that has been shown to be helpful. And from this kind of prospective study that they looked at, in patients that were propensity matched, there was about 197 in each group. For every 7 patients tested, there was 1 unnecessary invasive procedure that was avoided. So there is a clinical space for these. I think we need to know how to use them and in what population. So I'm going to give you an example of patients that I've seen and where we've used these biomarkers. So this is a 57-year-old female. She was an Asian non-smoker. She had this lesion on her CT that was not growing but stable over 6 months. It was 9 millimeters. It looks spiculated. You can see the fissure is kind of being drawn into it, and it was not avid on PET scan. And she was a lifelong non-smoker, but she was Asian. And when we calculated her Mayo lung nodule risk based on the clinical characteristics of the nodule and her risk factors, her risk was 12%. And so we did the biomarker for this patient, and we got a result of likely benign. However, we know that the trials of biomarkers have not been exclusively performed in populations of non-smoking patients and of Asian patients. There's more and more studies coming out of Asia now, but this biomarker was not tested specifically in that population. So we discussed this at our multidisciplinary tumor board, and John, of course, said take it out. But we said she's a non-smoker, we're going to do a biopsy first. And lo and behold, she had an EGFR positive non-small cell lung cancer, and she went to resection. So I think these biomarkers, there's a space for use, but it's also really important to know what population they were validated in. So this is another patient that we had that came through the lung cancer screening program. She actually was screened at the CHUM, but was seen at McGill for complicated reasons. But regardless, she had this lesion that looked like an early stage lung cancer. So I know I'm making a lot of thoracic surgeons' life more difficult with our screening programs, but you'll have to live with it. So she had this scan, and we decided to enroll her in the biomarker trial before her PET scan, because some of the role of this utility study is to see if we can avoid overuse of PET scans. And her biomarker came back as indeterminate. She did have her PET scan, and the lesion disappeared. So, I think these are still not perfect. We're not necessarily there for them to be used in real time, but it's something that we should have results of this trial. This was actually, I think, one of the last patients included in this trial in North America, because they now closed enrollment. There's going to be results published in 2025. So it's a patient I saw a couple weeks ago. She's a 73-year-old female. She had this lung nodule found on her CT. She's a non-smoker, but had a lot of secondhand smoke exposure and worked kind of in a restaurant her whole life when you used to be able to smoke in restaurants. And she has, I haven't yet results at her PET scan. She's booked for a PET scan next week, but her biomarker test said, well, it looks like it's negative. The negative predictive value is 97%. So I'm still not totally comfortable canceling a PET scan on a patient like this because I'm still concerned, but we'll see what her PET scan shows. I think if her PET scan is negative, I would be more comfortable with serial imaging given the location, but she'll be followed closely. So now moving on to, how much time do I have left? 5 minutes. Moving on to other kind of circulating blood transcriptomic types of biomarkers that are coming out. So there's large panels of microRNA that are available. I'll just go back, sorry. And you can't see very well, but there was a conversation earlier today about the utility in early stage. So you can see in early stage patients, right there, the AUC in 2 cohorts that had stage 1 and 2 patients. So some of these transcriptomics based microRNA sequencing biomarkers, while they're very expensive, they're showing promise in early stage, but again, not evaluated as part of clinical utility studies yet. They're quite small studies. We talked also about circulating tumor cells and tumor DNA liquid biopsies. In stage 1, the use is a little bit limited, does not perform as well. I think what clinicians need to remember is that the AUC of models that use only clinical risk factors alone is 0.8 to 0.9 almost in some of the models. And so it's very hard to improve your AUC more than that when you add either a blood-based biomarkers or other tests. So the bar is already very high for prediction. One thing that one of these papers just came out last week actually in Cancer Discovery. I think one of the newer things that's on the horizon is a much less expensive biomarker. So it's a way of identifying DNA from dying cells that are released into the bloodstream. These dying kind of cells have DNA fragments that are digested and available to be kind of evaluated in terms of their length. And so you look at these DNA fragments, and the idea is these fragments may be different in normal cells versus cancer cells. So in a patient that has a lung cancer, you may have a different type of fragmentome, and you get this overall score that has different components to it. So the features are kind of the fragment profile, chromatic changes, and length distribution. Those are all features that all give you a score. So at the end of the day, it's simple for a clinician like me that says, okay, there's a high Delphi or a low Delphi score. And this is much cheaper than doing something that's based on kind of a known tumor mutation. So the cost is less, so it's more implementable at a larger scale, both in the lung nodule space and the screening space, but it's still, again, a very new technology. So this potential advantage is that it does have good accuracy. There is reported good performance in early stages and across all different types of histologies. And so I'll just focus in here, and you'll see that the curves. So those are 3 different cohorts that have the 3 different colors. One thing that I do want to point out is in older patients, so you'll see in the blue curve or a bluish purple curve, that's the group that are age 50 to 80 and are smokers. So the performance is not as good as in the whole cohort when you look at people who are older. So I think that there's still limitation of this technology, but it's something that is much, much, much cheaper than looking at circulating tumor DNA, and so much more feasible, and it's tumor agnostic. So it's a technology that's being tested in multiple types of solid tumors. And there's been some modeling work on the same paper that came out in Cancer Discovery last week on how this would impact lung cancer screening programs and how many patients we would need to screen if we implemented this strategy. So the idea is you tell the patients, well, you have a high Delphi score on your blood test. You really should come back for screening, because one of the big problems with screening in the US and not in Canada, because in Canada we're very organized, is that people don't come back. And so this would encourage patients to come back for screening. And it would also perhaps allow us to narrow into the patients who need to be screened who are higher risk. So again, this is really early data, but it's probably where the field will eventually move. So this is just a list of approved or kind of used biomarkers. And one caveat about approved biomarkers is that they don't need to show clinical utility necessarily. And so, there's a race to get these on the market. For those of us who are in Canada, the only ones that are available, so the Notify markers are available as part of clinical trials. And we're in the process of implementing kind of a radiomic, the Uptellum software, which is also approved in the US, but not yet approved in Canada at McGill. But that's a process that will take a lot of time. But there are biomarkers that are blood-based, but not. But the Uptellum software is a radiomic-based biomarker. So again, I just want to remind people, if you remember one thing about the utility of biomarkers, is just please remember this slide, is that it's really useless in the patient that's high risk. And you want to look at the literature with the lens of the lower to very low risk to know how it can help you change your practice. So that's pretty much my talk very quickly, so get back on track. I think, for a respirologist who runs a nodule clinic, I don't think that I'm ready yet to implement these in all patients. I think, these clinical utility studies that will come up in 2025, that will be helpful to know where we start using these types of technologies. And we're not where we are in the space of treating lung cancer, where we can now follow, circulating tumor. In the nodule space, we're way before that, and it needs to be much cheaper because we're implementing them at larger scale. Thank you.
Thank you, Nicole. We'll open this up if there's one or two questions. I just want to start with, you had mentioned multiple times that the Delphi test was much less expensive. Yeah. So what's the comparative, compared to the other tests? How much is the Delphi test?
It's about between $300 and $500 for the test.
And the others?
We're talking, so it depends which test you're talking about. Some of them can be $1,000, some are going to be $10 if it's specific, a marker or a platform made specifically for that patient, for that mutation. So it really varies in price, but it's nowhere in the same scale.
Any questions?
No? Okay.
So we'll go on to the next speaker. Thank you.